So, welcome everyone. I'm really happy to see here a full room, and we have also some people there online. This is our last lecture series before the summer break, so thank you very much for joining, even if we have finally sun in Luxembourg. I'm really happy to welcome Talita in Luxembourg. We started with a hot, nice walk yesterday evening, and just to show her a bit the beauty of Luxembourg city. And also for today, I try to invite, of course, people from the Luxembourg Institute of Health, but we have also people from the Observatoire de la Santé, and also a representative from the Luxembourgish Nod of Policy. So I'm really happy if you can introduce all of us there. And I thank very much Maria Ruiz and also Michael Schnell for inviting you, and they will present you.
Thank you for having me. Pleasure to be here, and thank you for welcoming me last night. I can't believe that it was warmer here than in Barcelona. I wasn't prepared for the weather, so yeah, it was great. Thank you.
Thank you.
Special, very special.
Very special. Yeah, I brought the sun to Luxembourg. Okay, Maria.
Yes, I'm going to present you. So I'm very happy to welcome here Talita. Talita Duarte is a senior epidemiologist leading the area of real-world evidence at a primary care research institute in Barcelona. She's also an assistant professor at the Erasmus University Rotterdam. Since 2015, she has been involved in project leading different research projects using electronic health record databases. And she has a background in nursing and holds a master in public health and PhD in biomedicine by the University of Fabra. She was also a postdoctoral fellow at IARC, the International Agency for Research on Cancer, where she was involved in the EPIC study focusing on the role of diet, body adiposity, and metabolomic on cancer development and discovery of early cancer biomarker.
Thank you, Maria.
Thank you very much.
Nice introduction. Thank you. I'm very happy to be here today. So thank you for the invitation. This is very nice. So yeah, let's get started. I have a lot of slides. I hope I don't bother you too much. But yeah, this is a little bit the agenda that I thought for today. So the idea is that we start with a very simple introduction to what is real-world data and real-world evidence, which might be too basic for some of you, but hopefully helpful for others. Then we will talk about a common data model for network studies, and I will mainly focus on the OMOP common data model, which some of you are already quite familiar, so that might be too basic for you. And then I will describe some European initiatives like EDEN, initiatives on mapping of data to the OMOP common data model like EDEN or Darwin. And then I will give you some example of studies that we are doing or that we've done in the area of cancer and talk a little bit about the future research in cancer. So I hope that's okay. Let's get started with the introduction. I think that everything really started with the digitalization of health records. Can you see?
I can see, no worries.
Yeah. And I think that, I don't know if you remember going to see a healthcare professional and they'll be like writing in paper all the information that you give them. I don't know how many of you, I'm not gonna ask your question, but how many of you remember doing this, like going to see a healthcare professional and they will be like their paper writing? Can you? Yeah. Oh, many of you actually, okay, and also that old then. And in Europe, do you remember more or less when that happened? Like the last time that you got like a paper? Hopefully you haven't been to doctors that often, but more or less, no?
It would happen yesterday.
Yesterday? Oh my God, really? Oh, really? Okay. All right. I was gonna talk, like, yeah, that doesn't happen anymore in Europe. But there's still that many places in the world where this happens. But what happens with that, and that's, I think it's unfortunate because now, with all computers and everything, we should be in the other part, which I will show you in a bit in this presentation. But I think what happened then is like you will record information in this kind of paper. Where sometimes it's like you can barely understand what is there. If it was my handwriting, nobody would understand. And then this information will be stored in like big rooms like this. So whenever we wanted to do anything with this data, we didn't know where to start. So it was very difficult. Maybe it's still very difficult in some places. And I think the digitalization of health records started in Europe mainly towards the end of the 90s and beginning of 2000s when, for example, in Spain, all the primary care centers use electronic health records, for example, to collect information. And this is the reality that we have today in many places where you go see a doctor or nurse and there's a computer in front of them and they are like asking you questions. Sometimes they're not even looking at you, they're just like busy filling in information in their computer. And then what is good about this is that then this information is stored in these big rooms again, but with these machines, the surveys and servers. And this makes it possible for this information to very quickly go back to a computer so we can analyze it and do research with it. And I think that's where we are right now in many places, and unfortunately not everywhere. So what is real-world data? This is one of the definitions of real-world data. So it's data relating to a person's health status and or delivery of healthcare routinely collected from a variety of sources. So I know some of you are already familiar with this, and what would you say is real-world data for you? Like, can you tell me some examples of real-world data? No? You got this.
It's some data from the smartphone.
The smartphone, yeah. That's real-world data. Anything else?
Pathology report.
Pathology report and registries, for example.
Claims data.
Claims data, okay. We're almost there. Hospital data, yeah. Electronic health records that include hospital data or primary care data. This is a list that I had here. It's not everything, but mainly electronic health records which could come from hospitals or primary care. Claims or billing data, registries which could be cancer registry, disease registries, or mortality registries. Patient-generated data, which could be anything that is collected in your like digital watches or wearables and all that, and other digital information, which could be social media, for example, or other types of digital health technologies. And then what is then real-world evidence? So this is another definition. It's a clinical evidence derived from analysis of the real-world data regarding the usage, benefits, and risks of medical products through the application of research methods. So most of these definitions come from agencies like this one, I think, is from the FDA. So they're very focused on medical products. But of course, you can use this data for other things. And I'll show you later on today some of the studies that we've done, like, for example, on obesity and cancer, or different things that are not related precisely with medicines. And then I was going to ask you, but what do you think that, like, how can we use this data and what is it useful for? So I think the real-world evidence plays a key role in supporting regulatory decisions and approvals, and we'll see now, we'll show you the example of Darwin that some of you might have heard about with the EMA, also informing clinical guidelines in decision-making, providing timely evidence for payers and policymakers on the values of the intervention of treatments, as well as monitoring safety and effectiveness of post-market approvals of drugs and vaccines. No? So these are just some examples. It's not everything, but these are the main things that we are actually working on. Some types of studies, again, you can do a lot with this data, and this here is just some examples. We're doing a lot on trying to understand the natural history of disease, so doing patient characterization studies, descriptive epidemiology, where you could look into trends of incidence and prevalence of cancer, for example, over time, looking at treatment use and patterns over time. So basically, we can see how, for example, the treatments for cancer are changing over time, and describe that information, and how it could vary by population, for example, depending on the age or the vulnerability of the population. We can also do studies, as I mentioned, on safety and effectiveness of medicines and vaccines that have been approved and are out there. We can do predictive modeling, health economics, there's a lot on that too. Feasibility studies, which I think are very useful, because you can also even see if it's feasible to do a randomized clinical trials, if you can actually identify patients in the real world for clinical trials, for example. Strengths. What are the strengths of this? Please interrupt me at any time, right? If I go too fast, or if you have questions, please feel free to interrupt me. But these are just some of the strengths that I listed here. So these are data that is based on the real clinical practice. So this is data collected routinely in clinical practices, and I think it represents the reality of who is actually getting a treatment, what are the effects in the real world, like of not having just one drug, but having multiple drugs at the same time. And this is what differentiates it from randomized clinical trials, because here in randomized clinical trials, we have a very selected population. Usually patients are healthier and with less comorbidities than in the real world, so the people who actually are getting the treatment at the end of the day. I think large and representative populations, this is another thing. So we have, for example, the data that we work with a lot in Catalonia, it's called CDAP. So we have data from 75% of the population living in Catalonia. There's like 8 million people following over time. So I think this is one of the values. Price and speed. So usually these studies are much faster and cheaper than if you compare them with clinical trials, randomized clinical trials, or even the traditional cohorts that we've done in the past and we're still doing. It allows for more comparisons than what can be done in randomized clinical trials, because you can see the reality of patients are not just getting one treatment, but they are getting multiple treatments at the same time. You also have information on healthcare use, costs of treatments and care that you can use for health economics, for example. And there's a lot of flexibility on study designs, and this could be seen as also a limitation, because sometimes if you use it wrongly, you can get the wrong answers, and it's very easy to miss things when you work with this kind of data in terms of methods. So it's very important to be very careful with how we use the data. Here are some of the limitations. I think this is just both strengths and limitations, just a selection of the things that I thought were the main things, but of course there are other things. Of course, potential bias, so selection bias, indication, immortal bias, among others. So I always say that with this data, we need to think also a lot about what we are not seeing, because what we are seeing is the people who actually seek for care. But sometimes what matters is actually what we're not seeing in the data, the people who are not going and why they're not going. So it's important to be careful with that. Data granularity, quality, and completeness. So there are many electronic health records databases out there, but the level of quality and granularity of the information really depends on the way that information is collected, how healthcare professionals are aware of how this data is going to be used in the future. And we've seen with the data that we work in Spain, for example, how quality has improved over time, thanks to making healthcare professionals more aware of the use of this data for research. And completeness. So I don't know, maybe if you're interested in genetics and you might not have this information collected in electronic health records, So it's important to always think about, okay, can I answer my research question with this data, or should I look for another type of data? Data linkage and privacy is an issue. Ideally, you have data from hospital, primary care, registries, everything connected. I think there are some countries, like the Scandinavian countries, where they manage to do that, but I think we're still, in many other countries, far from there, from getting there, and it's all this privacy issues, on like confidentiality that we are, I think this is when using a common data model, it's really helping us to do network studies, and we don't have to share individual level data anymore. We're only sharing results, and we're trying to find solutions for this, but it's a bit slow, I would say, with the privacy issues. For example, especially with the environmental epi studies that we can discuss later. And the heterogeneity in healthcare systems, I think this is a limitation, but can also be something good, especially I think if you're able to do network studies using databases from different countries, you can actually compare them healthcare systems, and I think this is also one of the values and more than limitation. And then data collection and structure. So I think this is something that we'll talk about in a minute about the common data model, why we need the common data model. So just an important point, I think more real-world data does not mean more real-world evidence. But we do need studies with more than one data source, because usually of these things that I just commented on, differences in healthcare, differences in completeness of the information. So I think it is important that we do more studies with many databases and not just one. But we need to be very careful with how we do it. So okay, this was the first part, probably very basic for some of you, but now let's move to the use of the common data model for network studies. Okay, I think you're all very familiar with this map. This is the world of political borders, and I don't know, I think it's very clear that depending where you're born, you might have access to different quality of healthcare. These days, unfortunately, it's the reality that we have, and I do dream with a world with no borders, where everybody has the same rights, and where, you know, being born in a place in Africa means exactly the same as being born in Europe, but we're not there yet. And thank God there's some other crazy people like me in the world, these Odyssey people, who believe the same, and this is the Odyssey community, and I'll talk a little bit more about this common data model and how we are trying to get data across the world in exactly the same structure and being able to analyze it together. So this is, the Odyssey is the observational health, data sciences, and informatics. Who here has heard before about Odyssey, apart from you two? Some of you? Okay, oh, not bad. That's nice. So Odyssey is an open science community.
She also heard about it.
Oh, okay. That's good. That's nice that people participate online too. And this is the map of data partners. So people, I mean, countries where we have some kind of information mapped to the OMOP common data model. It's, as you can see, it's a big community. There are more than 400 databases that have been mapped to OMOP across the world, representing approximately 12% of the world population. So still a lot of work to do, but we're getting there. This is the definition as a multi-stakeholder, interdisciplinary, collaborative to bring out the value of health data through large-scale analytics. All the solutions, which this is what attracted me to Odyssey, is that all the solutions are open source and everybody's invited to participate. It has established an international network of researchers and observational health data. And I put here some links. So this is the Odyssey website. You also have here the book of Odyssey, where you can find a lot of information about Odyssey and the OMOP common data model. And I always also put here the link, the YouTube link, because there is a lot of tutorials that are out there. And if you're interested and want to get started, there's plenty of tutorials, and you can just start watching these videos and get familiar with what is Odyssey and what is OMOP. This is the mission: to improve health by empowering a community to collaboratively generate the evidence and promotes better health decisions and better care. And these are the values, which I'm not going to describe, but of course, innovation, reproducibility, community, collaboration, openness, and beneficence. And I would just like to highlight the community, so everyone is welcome to actively participate in Odyssey. And the ones who are already familiar with it, you know, there are many working groups, which I'll show you here, that you can just sign in. There are meetings every month. Each working group, they meet at least once a month, and they have discussions. And they are also conducting network studies, and you can also, even if you don't have data, you can participate actively and suggest that something, you know, if you could even lead a study without having data by suggesting the study within the network. There is a working group on oncology, so there's been a lot of work done on more vocabulary, and I think now is the time that we really need to start doing some studies with the databases that we have. And the OMOP common data model is the Observational Medical Outcomes Partnership. Sometimes I have to remember myself about what it means. It's a system of tables, vocabularies, and conventions that allows observational health data to be standardized. It is the standard approach that facilitates rapid innovation in the areas of open source development, methods, research, and evidence generation. And I think it's clearer with this figure here, actually, what is OMOP. So basically, we have different types of electronic health records with different structures using different vocabularies. And what we want is that all these different databases look exactly the same. So we want to put them exactly in the same structure with the same name of tables, with the same vocabularies. So we can then create standardized analytical code and of course generate open evidence. I think this is the main goal, and this is what we've been doing for a few years now. And I think what is nice about this is that, yeah, again, we don't share individual level data anymore. We share scripts, of analysis. So whenever we have a network study, we write the code using our data and we send it around, and people can just press run in their data and then send back the results. And this, makes things much
Which means
easier.
that we get the result by institution or by
Aggregated.
dataset.
Yeah, so it's a database and you get aggregated results, so you don't see individual
By
data.
institution.
Yeah, exactly.
So
Institutional database, yeah.
Okay, d'accord.
Yeah, we don't
So you cannot combine, for instance, if you have a small, I don't know, disease with small number of cases, you cannot combine.
We don't do it. You could, if there's an agreement and people want to share their data. This is actually being done in some projects, for example, for rare diseases, where people come together, maybe even create like some kind of registry of a rare disease and map it. And then you have data from different countries already in the same place. It is possible, but it always depends on the agreements, and this is where things become a bit more difficult, I would say. Because sending individual level data is always difficult, but for rare diseases, I think this is becoming more common. But of course, the agreements, sometimes we did a study to validate, for example, cancer diagnosis in primary care, and it took us 2 years just to sign an agreement with the cancer registries to link the data, and it was to use it only once for a validation study. And it was 2 years of like the pain of going to talk with I don't know how many people, and until you get a signature and you're like, hey, now we can do it. So yeah.
Maybe I can add, you could also run a query in order to get enough members in your cohort. So one registry or one place is not enough to have the statistical significance. You get it from, let's say, 10 registries, and then you do have enough in terms of numbers for statistics, and then you run your analysis. But you're getting only back the summary aggregated results. You're not getting really the analysis in the individual sites.
Yeah,
But
so
you
you
can bring this up to the level. A small one is too small for statistics, but together they are actually able. We have examples for that.
Okay. Thank you.
Sorry.
It's fine. This is how it looks like. So for example, in CDAP, I'm sorry, I always mention CDAP, but it's the database that I work the most. We have a table called diagnostics for all, where you have all the conditions, So we moved that table to a table called, I think it's, what is conditions? Condition occurrence. And then all our diagnoses are coded as with ICD-10 codes, and we have to map all those to SNOMED codes. So this is the process of mapping, can take time, and it's not that straightforward, but there are also a lot of tools that have been developed by the Odyssey community to facilitate the process of mapping. But it always depends on how well structured your source data is. So if you have a database where most of your information is based on like local codes and pretext, that makes things more complicated. So I think, again, the value is that we go from patient level data to evidence through the creation of standardized methods and tools. And there are many, as I mentioned, many tools that have been already developed to help you with the mapping of data, but also with the analysis of data. And I will mention later some of the packages that we've created for Darwin, for example, but within Odyssey itself, there are many, many tools and packages that have been developed. There is one, for example, the cohort diagnostics that we use a lot for all the studies that we do. And it's very helpful for phenotyping. So when you have a definition, you run it, and you can see all the codes that were used to define a specific condition and the counts in each database, and you can look into incidence over time and see if it's distribution of characteristics of the patients or the people that you have in your cohort. So it's really helpful to understand the quality of the data for a specific study. So we always use it before running the analysis in the study. But just to say that there are many tools that are being increasingly used. You can see here, this is the number of downloads of these tools over time, so you can see how it's growing. Of course, the number of databases that are mapped to the OMAP common data model is growing as well, so it's what we expect. The Atlas tool is very useful to explore your data. So if you have data mapped to the OMAP common data model, you can use it to look into your data, see how the distributions of recording of different information over time happens. You can look into incidence prevalence, but it's very useful also to design your analysis. So we can use it for like defining variables, defining cohorts, and then even running some analysis. And what it generates, it actually produces, you use this interface, and at the end, you can export the code and then just run it in R or whatever you wanna use. So it's very useful. And this is the number of publications of Odyssey over time. I think this is up to mid-2023. And you can see how it's increasing. But again, you always also have more databases mapped to the OMAP common data model as expected. Okay, so now we can move on to some European initiatives. And I would like to start with the European initiatives for mapping data that I think you're familiar with. I think in Europe, everything started with the EMIF project, which was an IMI project, the projects that are funded by the European Commission and the industry, and it started in 2013. I participated in the project starting mapping the CDF database in Spain. And then once EMIF ended, Eden started. I think that's when you guys started mapping data. And Eden was huge because, I mean, it's still happening. It ends, I think, September this year. And now they're talking about the creation of the Eden Foundation because we've built a community, a network of almost 200 databases. So the main objective of Eden was really to map data across Europe to the OMAP common data model. And you can go, if you're interested, you can go into the portal of Eden. And what is very nice is that you can explore, if you go to data catalog and network dashboards, you can explore all these databases. You can select a country, you can see the distribution of the population that you have of mapped data in terms of age and sex. And then you can even explore some counts which are rounded to, I don't know, 1,000 or something like that. But you can see, oh, I want to do a study on obesity and cancer risk. Where can I find the data? So if you go there and you type BMI, for example, body mass index, weight, height, you get information and you see which of these databases actually have information on BMI or obesity diagnosis. And you can also look into cancer, of course. So you can type, I don't know, breast cancer, and you see how many of these databases have records of breast cancer. So I think it's very useful. There's also the Eden Academy, which is, I think, very useful if you're getting started, because there's a lot of courses on like the tools and how to map data, how to use the analytical tools. So I really recommend using that if you're getting started, and it's free. You just need to log in. And yeah,
can you access the data from the Eden? No.
Yes, you can go to the portal.eden.eu, yeah, and you need to log in. But to log in, you need to create an account or something, but everybody can you just need to do it. And then you can access to the network dashboard, to the database catalog, you can use the Academy, you can use all this different
But you don't access the data.
No, but you don't have access to the data, but you can see it's like a catalog of databases.
Okay.
Which is very nice because you can see from these like 187 databases across Europe, if you type breast cancer, it will tell you an approximate count of records of breast cancer in each of these databases. Do you know what I mean? So it's not like, it's rounded, I think, I don't remember, it's 1,000 or 100, but...
And you have a contact to...
And you have the contact. You can then go inside, in database catalog, you go into the database and you have a description of that database. And then you can, there you have contact people for each of these databases. So,
okay.
So it's not, you can't complain if you don't have data, there's data out there.
Yeah,
and,
that's great. It's very,
yeah. Yeah.
And in principle, where do you, in this field, I'm coming from another field, from transcriptomics, from molecular methods.
Yeah.
So we have tons of databases where you can go and download the data to play with. In your world, in your field, where people could get the data in principle.
Well, so
Does
it
it
depends. For example, you could use synthetic data to develop your analytical codes if you don't have data yourself. But then usually, if you want to get access to the data, it has to go through, you need to go through different institutions who are like data providers.
So the solutions which are available for entire world.
It's not there yet. No.
It's planning, but it's not yet.
It's not there yet.
And synthetic data?
Synthetic data, so even like if you go to their Atlas, this tool that I talked about before, Atlas has a free synthetic data that you can use to create your code, but it's free. You can just go in the, I don't know if I put a link here of Atlas now. Yeah. If you go to, I don't know if it's the demo is working, but if not, it's atlasodyssey.org. If you just type in Google Atlas Odyssey, you have a link and you can, and then there you can play with it. And you can play with the tool as well. I think it's very useful. And then, of course, we were able to generate some evidence. I'm not going to get into the details of these studies now, but maybe just to mention that I think for us, at least, it all started more with the COVID-19 because that was the perfect timing for us because we just had mapped our data. And CDF in Catalonia, together with South Korea, we were the first ones to have data mapped on COVID. So we had the opportunity to do a lot, actually, in the first months of the pandemic already with this data. And from there, okay, of course, now we've done a lot on COVID, but in other things as well, using OMOP data, and I'll show you a little bit later. European initiatives on cancer using OMOP common data model. These are some examples of some big studies that are happening right now in Europe on cancer. There's the Harmony study, which is focused on hematological malignancies. These are all, by the way, IMI projects or IHI projects. There's the Pioneer that was focused on prostate cancer, and Optima that we're working together with Andreas, which is focused on breast, prostate, and lung cancer, but also on using artificial intelligence techniques to analyze the data. So I'm not going to get into the details of these projects, but if you're interested, you can, we have the links here, and you can go and have a look. But what I would like to highlight is that these are projects using data mapped to the OMOP common data model, or projects where they're actually mapping data on cancer for that project. So it's part of the project is mapping data. And now I'd like to move a little bit to the use of OMOP for more like regulatory purposes. And this is Darwin. I don't know, I know you two have maybe heard? Yeah, you've heard. Anybody else has heard about Darwin at all? No. Good. And okay, so this is the That's good. So Darwin, the data analysis and real world interrogation network, is a federated network of data, expertise, and services that supports better decision making throughout the product life cycle by generating reliable evidence from real world healthcare data, and it's using the OMOP common data model. So basically, this was a big project. This was a call from the EMA, I think in 2021, but the project started in 2022. And the coordinating center is Erasmus Medical Center. I am involved in Darwin as I'm co-leading study operations. So we're leading a lot of studies, and I'll show you in a second the studies that we're doing. So basically, then the coordinating center is in touch with different data partners to run studies. And every year, the first year, there were 10 data partners that were onboarded in Darwin. Second year, under 10. And the idea is that for 4 years, we'll have like 10 data partners that are going to be joining. The decision of which data partners are included in the network comes from EMA. So it's not for us, of course, we can recommend, but it's EMA at the end of the day who decides which databases are being part of Darwin. This is the current situation that we have of data partners. I'm not going to go into the details, but mainly we have cancer registries, we have hospital data, we have primary care databases, the Danish health data registries, for example. We have claims database like the IQVIA Germany disease analyzer. Many databases. I'm happy to go into the details, but yeah, each database has a lot of particularities. And I will show you an example of a network study that we've done with different databases. So you see that each database can actually help answer different questions depending on the data that they have. So I think that these are the three main areas for which real-world data analysis can support regulatory decision making. And this is a slide from the EMA, it's not from me. This is what they are saying that we can do with real-world data. So we can support the planning and validity of applicant studies, so designing the design and feasibility of planned studies, the representativeness and validity of completed studies. We can understand the clinical context, so what I mentioned before, disease epidemiology, looking at incidence prevalence of a disease, clinical management, drug utilization, which are more descriptive studies, and then investigate associations and impact, and these are studies more on the effectiveness and safety of particular medicine or vaccine, and also evaluation of impact of regulatory actions. Maybe I will skip this one. I think this is just to highlight that if we want to scale up how we do research, we do need to use a common data model, but I won't get into the details. Again, generating reliable evidence using the OMOP can enable the standardized of analyticals, and this is a repetition a little bit of what I said before. And these are the studies that were the number of studies that we're doing per year. So we started in year 1 with 4 studies. Off-the-shelf studies are like the more descriptive studies, like looking at treatment patterns, disease epidemiology, looking at patient-level characterization studies. And complex studies are more looking into effectiveness and safety of medicines and vaccines. So we did 3 studies of the simple ones and 1 complex the first year. Last year we did 14 of the simple ones and 4 of the complex. And this year the plan is to do 30 routine repeated, which probably we won't make it because we haven't done 30 studies yet to repeat them. But 30 of the simple studies and 12 complex. And next year, so year 4 and 5, it's really when we double the amount of studies. So it's like 60 routine repeated, 60 simple studies and 24 complex studies and 1 very complex study. So you can imagine that, to do this amount of studies in a year, you really need to have the standardized tools. So this is what we've been working into the establishment phase, has been more like creating packages in R, for example, to look into incidence prevalence. A package to do treatment patterns, a package so this, I think what is nice about this is that these packages are out there and are available to anybody to use. If you have data mapped to OMOP, you can use it locally on your own data. So for example, the incidence prevalence package that we created, if you wanted to do a calculation of incidence and prevalence over time in R, you have like a code of maybe 1,000 lines. Now with the package with I think it's 15 lines, you can run an incidence and calculate incidence and prevalence in data match to the OMOP common data model. So it's just an example of how it can really help speeding up the process of doing research. These are some examples of some of the ongoing or finished already completed studies that we've done on cancer. We did the first year, we did a study on the prevalence of rare blood cancers. The second year, we did a multiple myeloma study that I will present the results now in a bit. These 2 studies are completed and you can actually see the reports in the EMA catalog. And these are ongoing projects. There's one that we're looking at overall survival of patients with locally advanced and metastatic non-small cell lung cancer, treated with selected immunotherapies as first line of treatment. And the second one where we're looking at effectiveness of the HPV vaccine to prevent cervical cancer. We are also doing a study that I forgot to put it here on frailty and polypharmacy in cancer patients, and that one will be finished pretty soon. And yeah, you can go into the website and check all the studies that are currently ongoing, and then you can go to the EMA catalog and see the reports that we are producing. I think, now it's the last part. I don't know how we're doing with time. Okay. So, yeah, okay, good. Now I would like to share some examples of studies that we've done, and I think because I just presented Darwin, I thought it would be a good idea to present the multiple myeloma study, where we did patient characterization, treatments, and survival during 2012 to 2022. So the disclosures and, well, why, I mean, multiple myeloma, what is multiple myeloma? I don't know if anybody here has worked with multiple myeloma. I guess maybe you a little bit. Yeah, there? Good. So multiple myeloma, for those who are not familiar, is a plasma cell malignancy which represents from 1 to 1.8% of all cancers and nearly 10% of hematological malignancies. The survival rates are improving over time. The last decade thanks to improvements in management and treatments, but still only 10 to 15% of patients really achieve or exceed the expected survival compared to the general population. And the rarity of multiple myeloma makes it really challenging to have a full picture of who gets the disease, what are their characteristics, and what are the treatments that they're getting, and what is their survival. So we did this study to, of course, this was a request from the EMA. We always negotiate and discuss the studies, but it came from EMA to describe the demographic and clinical characteristics of patients with multiple myeloma, to describe their treatments and treatment sequences, and to estimate the overall survival of multiple myeloma patients during 2012 to 2022. We did a cohort study where we included all patients with diagnosis of multiple myeloma between 2012 and 2022. These were incident cases, so with people with no prior history of cancer. We created 3 cohorts that I will explain in a bit, and these were the databases that we used. So you see that they're very different. IQVIA Germany, it's a claims database. CDAP is a primary care database in Spain that is linked to hospital discharge data. Then IMACIS is the Hospital del Mar in Barcelona. It's a hospital data. We have data from the Estonian Biobank, the Clinical Data Warehouse of Bordeaux. This is a hospital data in France, and NCR, which is the Netherlands Cancer Registry. So you see that very, very different data, and that's why we had to create the different cohorts that I will mention in a bit. We did a large-scale patient-level characterization for the first objective, where we basically described everything that was recorded prior to, in different time periods. So before the diagnosis of cancer, at the diagnosis of cancer, the month before diagnosis of cancer, but all comorbidities and medications were described. We looked into cancer treatment for those databases where we had data on cancer treatment. We looked into the number and percentages of patients getting like a list of pre-specified treatments. And we then calculated survival, the 1, 3, and 5 year survival. And we stratified by age, sex, and study period. And of course, it was all stratified by database as well, because we get the results from the different databases. And these are where the packages, our packages that we use. We use cohort diagnostics, the one that I mentioned before, that is very helpful for phenotyping, patient profiles to get the large-scale characterization, treatment patterns for the description of treatments, and cohort survival, which we developed for this study, and now we're using it for many other studies to calculate survival. And here are the numbers. So this is the number of people. This is the population in each of these databases. So the biggest one here was DA Germany with 41 million people. Then we had CDAP with 8 million, IMACIS 1 million. The Estonian Biobank is smaller, but they do have a lot of information. They have genetic data, they have a lot of detailed information. And the Bordeaux Hospital with 2.3 million, and NCR with 2.3 million as well. And from there, we selected patients with multiple myeloma, and we created these 3 cohorts. We excluded those with history of cancer, and we created 3 cohorts. One where we forced people to be in the database for at least a year before, so we could capture all their comorbidities and their medications before the diagnosis of cancer. And you can see here that NCR didn't have that information, so the Dutch Cancer Registry, because they don't have information before the diagnosis of cancer. We created another cohort to look into treatments, and for that we forced that patients had to have a minimum follow-up of 30 days, so we were able to see any treatments. And you can see that CDAP and Germany, we didn't have any information on treatments, so we didn't create those cohorts here. And then the third cohort is the one that you have a minimum of potential follow-up of 1 year, and this was for the estimation of survival. And you can see the counts here for multiple myeloma. The biggest one was NCR with 11,000 patients, and then followed by DA Germany with 6,000, and CDAP with almost 4,000. Again, the Estonian Biobank is quite small, but still you have very detailed information, it's still, like, I think, very valuable for research. This is the distribution of these patients, the age and sex distribution. So patients went from, this is the median of age that went from 66 in Estonian biobank to 75 in the hospital data of Spain. And in terms of sex, it was very similar distribution among males and females in, I would say, IQVIA Germany, Estonia, IMASIS and CDAP. But then in NCR and Bordeaux, you had a higher proportion of males than females. In terms of comorbidities, so this is history of comorbidities among patients with multiple myeloma. We saw that these were the most frequently recorded comorbidities for these patients: hypertension, osteoarthritis, hyperlipidemia, among others, diabetes, obesity, anxiety. We didn't observe differences by sex, but when we looked by age, we did find that in younger patients, anxiety, depression, and asthma were quite common, while in older patients, renal impairment was one of the most frequent comorbidities, which makes sense with the diagnosis of multiple myeloma. Here you have the treatments. I won't get into the details, but mainly we have the most frequently used treatments were glucocorticoids, chemotherapies, and proteasome inhibitors as well. We also had some immunomodulatory agents, and I won't get into the details perhaps because of time. But yeah, we looked into survival, and here you can see in Bordeaux, NCR, the Netherlands, and CDAP in Spain, the survival curve in females and males. We didn't find big differences between them, but you can see, for example, that CDAP, which is a primary care database, and NCR, which is a cancer registry, they have almost the same curve, so they were very similar. While in Bordeaux, you see this better survival of patients, but this is because they only had deaths that occurred at that moment, they only had deaths that occurred during hospitalization, so you're missing a lot of patients who might have died outside the hospital. And yeah, we looked into differences by age, and as expected, older patients have lower survival than younger patients. We looked into time, so yeah, periods of time, so before 2018 or 17, or later, and we didn't find big difference. Now we're only looking here at 3-year survival. In NCR, you can see that the curves are starting to separate, so we want to replicate the study hopefully later on and see what's going on. Hopefully there are good news and survival is actually improving with the new treatments, but we couldn't see it very clear here. These are just some conclusions, but I think it's important to highlight that we did this study on 30,000 patients newly diagnosed with multiple myeloma, making this one of the biggest ever studies conducted in multiple myeloma, the biggest in Europe for sure. And we described treatments. We saw, I didn't mention this, but we saw that, for example, immunomodulatory agents and proteasome inhibitors were less used in older patients, and yeah, as you could expect. And the survival probabilities vary by age as well, and it's something that we expected. I'm almost finishing my presentation, but just before, I think I focused it mainly on network studies and how important it is to do studies using different databases, but I just want to have one slide saying that also using a single data, you can also do very useful studies, and these are just some examples that I picked this morning that I wanted to share with you. For example, we did a study where we looked into risk of diagnosis of COVID-19, hospitalization and death among patients with cancer using only the CDF database, but using the OMOP common data model. And it's just to say that once you have your data mapped to OMOP, you can do studies with only your data, but having the tools in place, it really helps you to make these studies very quickly. We just published, I think last week, this study on the effectiveness of COVID-19 vaccines in patients with cancer in Catalonia. This is a study that I think it was also very important, looking into the socioeconomic inequalities of COVID-19 vaccination in Catalonia. And this is one of the things that is difficult to do as a network because standardization of socioeconomic indicators is difficult. And this is another example in the area of environmental epi that I'm very proud of, that we managed to link, air pollution and green spaces, and we looked into the relationship with breast cancer, for example. But these are just few examples of things that we've done with our own data that I think are still valuable. And then just to end with some final remarks and opportunities, I think what I've tried to show today is also the importance of collaboration, especially when we're working and we want to solve a global problem like cancer. So I think it's very important that we collaborate. I try to show a bit also the value of using a common data model for real-world data to provide comprehensive, valid, and reliable evidence. And I think this is a very important point, that collaboration requires transparency. So I think when we're working with data in OMOP, all the artifacts of our analytical pipeline needs to be publicly available. So it's very important that we have a very good documentation of our ETL, so how we mapped our data to OMOP, but also that we do the data quality, how have we mapped it, we prove that our mapping was done well, and then that when we're doing a study, that we publish our protocols, that we publish our code, and that we make our publications open access. And I think by doing this, we are also encouraging other people to do the same and share their code. I think it's important for transparency, but also it's the key for being able to reproduce studies. It's important for the interpretation and for trust, I would say. And I'm almost done. So of course, I hope you have this idea now that real-world data can help us generate new hypotheses for clinical trials. It can complement, improve, and generate new knowledge compared to what we already have from randomized clinical trials or cohort studies. It can improve the safety profiles and evaluate the effectiveness of new medicines and vaccines that are out there in the real world. It can support the regulatory decisions and approvals, and it can inform clinical guidelines and decision making by generating real world evidence. Real world data is a powerful tool to help advancing in the research for and fight against cancer, I would say. But of course, there are some challenges. But I think with these challenges, they come with opportunities as well, and these are the things that I think we still need to work on. Some of them, so for example, using the right data and the right methods to answer the right questions, so that what we say fit for purpose, you need to make sure that the data that you have can actually help you answer the research question that you have, and that you use the right methods for it. I think we still have a lack of data from Global South, and you can see here, this is the map of collaborations, and when I show the map of data that is mapped to OMOP, you can see that there's still the gap here in the South. It's something we need to work on. There are still challenges with the standardization of some data, and also the analysis of data on socioeconomic indicators, the free text that is there. And images, this is also for cancer, is very relevant, and I don't think we're there yet to, especially with OMOP, to analyze images. The lack of linkage with environmental exposure, so we've done that with CityApp, and now we're having issues for privacy issues, they're not allowing us to link the data anymore because there's a high risk of identification of an area where you could maybe identify someone. So it's becoming more and more challenging to do this kind of studies, but I think it's very, very powerful for this kind of research, as we already proved with the studies that we've done in the past, looking into obesity and exposure to air pollution, green spaces. And finally, the no collection of data that is important for patients, for example, quality of life, things that are not routinely collected is also one of the limitations. And I'm done, sorry. I'd just like to thank the team of the Real World Epi Research Group in Barcelona, at Epidemiology, and then of course my colleagues from Erasmus Medical Center, the Darwin EU, and the Odyssey community. And I think maybe some of you are in this picture here. This is from the European Odyssey Symposium from last year. So you might be somewhere there. I don't know.
You were there.
Oh, yeah.
You see yourself? Yeah. So thank you very much, and really looking forward to the session.
Thank you so so much for your presentation, this great overview, and especially your extraordinary work you are doing. So congrats for that. And maybe for some questions. So the Luxembourgish journey of Odyssey started also straight after COVID, so 2021. We joined the Eden project. We got the money to map the cancer registry data. It was mainly David and Michael who joined that, and then together with the forces from the ITTM, so from Andreas, we started to map. So this is the first source we had mapped, so we did that. But of course, what I can say is also from a resource perspective, it's a lot of effort additionally. So of course, afterwards now, we hope that the story starts, so we can join studies and publications.
Now the fun starts.
Exactly, but it's a huge effort additionally. So it's great that the European Union has an additional fund for this. Otherwise, it would not be possible. And also now, so we created this node because a lot of people say, why are you doing that and what's the value out of it? So it's great also to have that. And of course, we have some other population-based cancer registries from Norway and the Netherlands and also Switzerland who join, where we have coffee breaks regularly to discuss our problems. And
I want to be there.
This is really great, and also some join. So thank you very much for joining online. Nice. So the floor is yours. If you have any question, also people online, please feel free to raise your hand, unmute yourself, or just write a question in the chat. Any questions in the room?
Is it that boring?
So they all congrats. But there
I have just one question. If I see that you have one of your main challenge, let's say, is to standardize, let's say, free text image, so everything that data. Do you have already a strategy for this? What is your, let's say, objective? How can you handle this type of data?
Those are two good questions. One, can you have, let me start from that one. Can you have that kind of data? It is, some databases have that information. But then, for example, in CDAP, I'm sorry, I'm always talking about CDAP, we do have that data there, it exists, but we're not allowed to. It's not that easy to analyze because of for privacy, let's say, issues, because you can identify people. In free text, you have names and surnames, names of family members. So they've done, for example, they've created a software to anonymize free text first. And I think we're getting there, but it's still a lot of work needed. There are other databases that have a lot of information on images and free text as well. And some people are doing there. I think there's a working group in Odyssey that is working. Maybe you know more about it. So if you're interested, I would say just join one of these working groups and see where they are. I can't really say the details, but I know there are people that are doing work on this in this area. But I think it's still a challenge because it's not that easy to, even like not working with a common data model, the analysis of images is very challenging. So.
Yeah, there's a work group on imaging and there's a DICOM standard for the imaging, so to bring this together.
Good. There's so many working groups.
Sorry, if you speak of imaging, it's medical imaging or what kind of?
Yeah, I was thinking, more like, the pathological results we can have.
So OMOP and the common data model and also the software tools, they are very strong in doing this kind of transversal combination across databases of information and extracting the parameters, and then if possible bringing them back for statistical analysis to pick one outcome. But are there efforts also to take care, for example, also Luxembourg is now going into the direction to push more pseudonymization of data that allows to connect data across different types of information for the same person across different databases spread out. So that to bring this, to enable this also more in the Odyssey Darwin environment, is there some effort there?
Do you mean linking different databases for like the same person? Yeah, I think this is more something that needs to happen in the source more than the common data model. So this is, OMOP is once you have a database, you're mapping it to this common structure. But this needs to be done more on like a local level. So for example, in Catalonia, we do have a unique identification number, and we could link everything, but there's always political and other reasons why we don't really have that linkage, and I would say in Catalonia, while in Scandinavian countries, this is been done for a long time. I don't know in Luxembourg if you have a unique identification by your race. I can say that that's still far.
We are not there yet. It's a sensitive topic. We also need some other.
That wasn't a joke, but it generated some.
But we also have the we would love.
Yeah. Yeah. I mean, and it's also for healthcare, for like a person, you know, a patient. If you have the information, like, what do? Do you go see your doctor with your like files and like, here, this is the result of my? No, I mean, it would be really nice if everything could just be linked, and if you travel around, that people know that, oh, this person, I have their ID. Even in Europe level, I would say, it's coming from Spain. Oh, they have an allergy to this medicament. I don't know. A person has an accident, and you have their ID, and you could know what is their history, clinical history. You know, I think for us, it's also as patients, it's a benefit to having that. But then
all the week, yeah,
in this room.
But I think the presentation and also the studies which are coming out and the new insights will help, you know, slowly to also show why it should be important. But in Luxembourg, we are not there yet.
You're not there yet.
Because there are the efforts now from the government has created an entity which should, or there's work going on to get this connected all with one unique identifier. But then would be the question, if the data is in an OMOP common data model spread out across different databases, how do we know how many patients we find back that fulfill the criteria across all databases?
Can you say that again, sorry?
If we have, for example, in the OMOP common data model in different localities, in different databases, the same information for the same patient, how could we know that we have enough patients to do a certain study across the different databases?
I'm not sure if all the question, but let me go to the
If we have a common identifier that allows to connect, the idea would be then to know how can we get the power to do the statistical analysis, having the data spread out across different databases to bring it together for the same set of patients, that we have enough information, because the pseudo identifier might exist in 10 different databases.
But you mean in the same country? So for example, let's say here you have
the constraints
data linkage.
Data linkage, yeah, that's the key, and that's what, for example, in Syria, again, sorry for the example, but we do have primary care and we have linkage to hospital database. In the common data model, there is somewhere where you can see where the data is coming from, so you can actually say, okay, I wanted the conditions, but the ones recorded in hospital, for example. Once you have this linkage, you can play with that as well. Like you can see where the data is coming from. For drugs, for example, in Syria, we have dispensation and prescription. So you can use it in a study, you could use only prescription or only dispensation or both to see, you know, if what's prescribed is actually then, if patients go to a pharmacy and pick up the treatment. But you do need that linkage is the key. Like you need to have that number that connects the dots, you know, like if you go to hospital, primary care, emergency room, that you need the linkage to have that. I don't know if I answer your question, but happy to discuss more.
For example, if perhaps I can ask later.
We have time afterwards too.
We can discuss later.
We have some people online. They also raised. So there is Michel, I think, and.
Yes, if I can. Thank you for the presentation. So you spoke a lot about mapping, and my question is whether if there's another another database using another terminology than OMOP, how is it possible to map that, especially if it is, for example, in the case of RCTs, the use of CDs, DTM, or whatever? Do you have tools in the Atlas, for example, that would map CDs to OMOP?
To map what? CDs?
CDs
here.
Okay, no, I don't think.
Okay.
Maybe you know. I don't know.
There are efforts out there to map CDs to OMOP. This is not at the moment on a broader way. This is very project specific. So in the Optima project, which you mentioned, we did actually CDISC to OMOP mapping, because one of the data partners had their data only in CDISC format, and so we mapped it into the OMOP. CDISC is the one you are using, subscribing to the FDA.
Oh, I see.
And there are other efforts to have converted. You might have seen the working group on FIRE to OMOP. That's another way to make sure that there is interoperability between the existing standards.
Thank you, Andreas.
Thank you.
Thank you, Michelle.
And then this
We have another, Katarina, she raised her hand. Could you unmute yourself, please?
Thank you. I don't know if we have enough time. Oops.
Yeah, of course.
And there is a... first of all, thank you so much for your presentation. It was so interesting, so concise. I really enjoyed it a lot. And so I have a more technical question. So what are the requirements? Because you mentioned before the RStudio packages. I wanted to ask, what are the requirements to contribute and write your own R package for data analysis that are in OMOP? And if you don't have time, we can maybe speak about it after.
There are no requirements, really. It's like if you want to, for example, there's a package out there, and I'll put an example because we need it. There's a package out there to calculate incidence prevalence, for example. But that package doesn't take into account data coming from registries where you don't have a denominator. So if you're interested in contributing to improve that package, for example, you could help develop something to help calculating incidence prevalence in registries. And then you can, I think it's all open source, you can publish it on CRAN and it will be out there for others to use. So I think it's, there is no really, I mean, you just need to show that it works. I mean, of course, when we create these tools, there are a lot of tests that are done to make sure that they work, and then we also prove it. Like you can also compare, for example, with the incidence prevalence, we compare the results that we got using the package with the results that we use using the thousands of codes that people use, you know, like the good thing is, like, I think what helped us a lot is with also transparency, because people, most of the times, they don't publish their code and you don't even know what it's been done, you know. So I think what is important is just to be transparent, and you can create, like with R, you know, you can create packages and just publish them on CRAN. And then for people to use this package, what is important is that you then prove that it works and that it's useful. So that's what I would say. But yeah, you're welcome to contribute to the community. Good.
So thank you so much.
Thank you. Thank you very much.
Thank you. So in conscious of time, I would suggest that we close the session. Don't forget, for those who are here, we have a lunch, so you still can have the time with Talita, ask your question if it was not clear yet. We have also recorded the session. It will be online on our website, so in case you want to share it with your colleagues or have other questions, please feel free so. And thank you so much again for being here and all for joining. And have a good lunch. Thank you very much.